We are lucky at the current time to have 3 approved BTK inhibitors for patients with relapsed refractory mantle cell lymphoma. Ibrutinib was the first one to be approved, but we now have acalabrutinib as well as zanubrutinib. And it's important to recognize that at least as of right now, these have not been compared head-to-head. And so it's difficult to really draw firm comparisons between the 3 with regards to their efficacy as well as tolerability. Having said that, we have seen some themes emerging. It does appear that some of the newer BTK inhibitors may have some decreased toxicity, although it's also important to recognize that acalabrutinib, for example, has been associated with an increased risk of headaches, whereas this has not necessarily been seen with ibrutinib. Having said all of that, I think one of the key facts to keep in mind is that the other BTK inhibitors were developed after some of the initial trials with ibrutinib showed promise. And in addition, many of the toxicities that we've come to identify with ibrutinib were already described at that point. And so maybe patients that were at risk for some of these toxicities might not have been put on this acalabrutinib or zanubrutinib studies. So really, in order to tell the difference between these groups, we'll need some head-to-head studies, many of which are being considered and are underway, but it'll be some time before we can really make any definitive comparisons. When I'm evaluating a patient in clinic, I often take into account a number of factors, not the least of which is the ease of obtaining the medication and whether one might be associated with a lower copay. I've had in my own practice some patients that have had a difference in copay of up to $100 a month between one and the other, and it's not always the same drug that is cheaper. So I think it's important to work with your pharmacy staff to see if you can get one of those medications at a lower rate based on the patient's prescription drug coverage. I think also, although there hasn't been direct head-to-head comparison, it does seem as if there may be fewer bleeding complications and cardiac complications with some of the newer BTK inhibitors. So a patient, maybe for example, with a history of atrial fib, but for whom I think a BTK inhibitor is critical, I might consider one of the newer versions of the medications. Having said all of that, at the end of the day, I really can't definitively state that there are significant differences between these therapies, and it often comes down to more practical matters like cost, and for example, that some require twice daily administration and others are daily, and what that means for individual patients. Despite the fact that we now have a number of effective therapy options and that patients with relapsed refractory mantle cell lymphoma are living longer than they ever have in the past, the overwhelming majority will unfortunately still die from their disease. And ibrutinib, as good as it is unfortunately still associated with an ongoing risk for relapse the further out you go, and we know that there can be ongoing toxicity. So for a patient with relapsed refractory mantle cell lymphoma, it's important to really balance this toxicity with long-term goals of care and long-term efficacy. Fortunately, we do have some other more intensive options that are out there. Allogeneic transplantation can, in some instances, be curative for a highly selective group of patients. And it's important, especially for our younger patients or those that have relapsed early or multiple times, to at least have this discussion about the potential role of allogeneic stem cell transplantation. In addition, many of you are likely familiar with the fact that CAR T-cell therapy, currently approved for large cell lymphoma, has been evaluated in mantle cell lymphoma and is very promising. I don't know exactly where CAR T is ultimately going to fit in the management algorithm of patients with mantle cell lymphoma, but certainly it will require discussion and will be an excellent therapy option for patients in the future. And then finally, I think it's important to recognize that many of these therapies work very well as monotherapy, but could work even better in the setting of a combination. And the hope would be that they remain quite well tolerated. So one good example is lenalidomide, which has been approved for mantle cell lymphoma in patients who have progressed after bortezomib. But we know that lenalidomide monotherapy is not nearly as effective as lenalidomide in combination with rituximab. And so, for example, I often think about using rituximab with lenalidomide in patients with relapsed mantle cell lymphoma. And my expectation is that there will be ongoing studies of combinations which may find that particular BTK-containing combinations are more effective than BTK monotherapy. So I think the future is very bright. There's going to be a lot of discussion and a lot of testing needed to figure out what is the right sequence of therapies, what is the right combination, and again, where does some cellular therapies fit in. And these are all the subject of intense debate and clinical trials in the current time.